Hi everyone, my name is Chelvin Sng and I'm a glaucoma specialist. Today, I'm very excited to share with you my experience with the YC200S+. These are my financial disclosures. Glaucoma is a life-changing diagnosis. It is a chronic disease which requires lifelong monitoring and treatment. The aim of glaucoma treatment is to preserve the vision-related quality of life. Lowering of intraocular pressure is the only proven and effective treatment and is the mainstay of glaucoma therapy. Let's begin with an overview of glaucoma treatment. To lower IOP, there are generally three options: medications, laser, and surgery. Medications are conventionally the first-line treatment for newly diagnosed glaucoma patients. While topical medications are effective, there are several pitfalls associated with the use of glaucoma eye drops. Reported patients' adherence rates are poor, especially if several eye drops are required. Eye drops are also expensive, especially the branded eye drops and the preservative-free eye drops, and the costs are cumulative. Patients often dislike using glaucoma eye drops because of the local and systemic side effects. This is a patient of mine who had a cicatricial ectropion, which resolved after stopping eye drops for a couple of months. Elderly patients often struggle to use eye drops, especially those with arthritis. And long-term use of glaucoma eye drops predispose to failure of conjunctival filtration surgery. On the other end of the spectrum, glaucoma surgery has attracted a lot of attention of late due to the emergence of MIGS. Conventional glaucoma surgery, such as trabeculectomy and tube implant surgery, are effective in lowering the IOP, but are associated with potentially sight-threatening complications, hence are usually reserved for patients with advanced glaucoma. MIGS has addressed an unmet need for a safe and effective option for patients with mild to moderate glaucoma, especially as a phacoplast procedure. However, standalone trabecular bypass MIGS still hasn't replaced medications in medically controlled mild to moderate glaucoma, as most patients would rather persist with the medications even with their side effects, rather than undergo surgery. So what is the role of laser trabeculoplasty in all this? Laser trabeculoplasty was first described in 1972 by Kresnov, who used a ruby laser on the trabecular meshwork to treat glaucoma. Argon laser trabeculoplasty was initially the vogue, but this has been largely replaced by selective laser trabeculoplasty, or SLT. Histological studies have shown that SLT causes less coagulative damage and scarring to the trabecular meshwork than ALT. The mechanism of action of SLT is predominantly through its biochemical and cellular effects by recruiting matrix metalloproteinases and macrophages without the damaging mechanical effects seen in ALT. It increases aqueous outflow through the conventional outflow pathway, hence reducing IOP. How is SLT performed? SLT uses a 532 nanometer Q-switched frequency doubled ND-YAG laser with a 400 micrometer spot size and 3 nanoseconds duration. There are various lenses that you can use, and I tend to favor the Vogue Rapid SLT gonioscopy lens because there are 4 mirrors, so you wouldn't need to rotate the lens much to get access to 360 degrees of the trabecular meshwork. I helped to recruit for the light study when I was working at Moorfields Eye Hospital, so I used the same laser settings as the light study in my clinical practice. I usually perform 360 degrees of SLT with 100 non-overlapping shots. I pre-treat the eye with brimonidine at least 15 minutes before the laser. This video shows SLT performed with the NIDEK YC200S+, which I have in my clinic. You can see that the view with the laser machine is very good as it has a high-quality optical system with LED illumination. The aiming beam is also precise with a sharp edge, so it is easy to focus. The spot size of the SLT is actually quite large at 400 micrometers, so you have to be precise to aim it over the trabecular meshwork and avoid either lasering the iris or the cornea, which can increase the risk of inflammation after laser or corneal complications. I usually start with about 0.8 millijoules for non-pigmented trabecular meshwork, but for pigmented trabecular meshwork, this will require lower energy, and I start the treatment at 0.4 millijoules. The desired endpoint is the production of champagne bubbles, and you shouldn't see larger gash bubbles or blanching of the trabecular meshwork. If these are seen, then titrate the power downwards in 0.1 millijoule steps. To help you to keep track of which area of the eye you have lasered, the machine helps to count the SLT shots and shows you the area you should be treating. So you can use this as a guide to ensure that all parts of the angle are well lasered. I will measure the IOP about 1 hour after the SLT procedure to ensure that there is no IOP spike. It is a bit controversial whether to prescribe topical steroids and NSAIDs after SLT, and there is a randomized controlled study which showed that topical steroids or NSAIDs may improve the IOP lowering effect of SLT. There are others who think that the inflammation associated with SLT is important to lower the IOP, hence discourage the use of NSAIDs or steroids after laser. In the LIGHT study, patients are actually just given 1 bottle of topical NSAIDs to stand by, to be used only if the patient has significant discomfort despite oral analgesia. Personally, I haven't found that steroids or NSAIDs after SLT make a significant difference in the IOP lowering effects. After SLT, I usually review the patient at 6 weeks to determine the efficacy of SLT, though you may also consider an additional review at 2 weeks to determine whether there are any complications from SLT. How effective is SLT? Though SLT is not a new technology, it has attracted a lot of attention recently because of the LIGHT trial. The LIGHT study is a randomized controlled trial which randomized more than 700 patients to receive initial laser or initial glaucoma medical therapy. The primary outcome was health-related quality of life at 3 years, measured with the EQ5D questionnaire. Secondary outcomes were cost effectiveness, disease-specific health-related quality of life, clinical effectiveness, and safety. What are the clinical benefits of offering SLT as a first-line treatment? Glaucoma progressed in a lower proportion of patients in the laser first versus the medicine first arm. Over 36 months, IOP control was better in the laser first arm, with more visits at target IOP, a lower number of glaucoma medications, and no glaucoma surgeries. Patient non-compliance with topical glaucoma therapy may partially explain these results, and there may also be less diurnal IOP fluctuation after SLT compared with medications. Remarkably, 3/4 of patients in the laser first arm were medication-free at 36 months. Hence, in our editorial in Eye, we recommended the SLT should be offered as an alternative to medications as a first-line treatment for newly diagnosed POAG. Is repeat SLT effective? In a follow-up paper on the LIGHT trial, about 2/3 of eyes which underwent repeat SLT were medication-free at 18 months. These results demonstrate that SLT can potentially maintain IOP at or below target IOP with at least an equivalent duration of effect to the initial laser. However, the LIGHT study only included treatment-naive glaucoma patients who were predominantly Caucasian. The Light in China study is currently underway, and the results will reveal whether similarly good results are seen for Asian patients. The efficacy and predictability of SLT was more variable in other real-world studies, highlighting that patient selection is important. There are less data on the clinical outcome of SLT in medically uncontrolled glaucoma, normal tension glaucoma, and secondary glaucoma, and the efficacy is likely lower in these contexts. Some studies have shown that patients with fewer pre-laser glaucoma medications experience greater IOP reductions with SLT. A couple of studies also found that the efficacy of SLT decreases with concomitant prostaglandins. This patient of mine would be an ideal candidate for SLT. Newly diagnosed early glaucoma in the left eye, baseline IOP of 26, and after SLT, the IOP was 18 at 6 months on no medications. Patient selection is important for SLT, and it seems to work best in the context of treatment-naive patients or those with mild to moderate glaucoma on few medications. How safe is SLT as a primary procedure? The rate of SLT-related adverse events was low in the Light study, with IOP spike occurring in only 1% of patients who underwent SLT. This is lower than that reported in other SLT studies and could be because performing SLT at an earlier stage of the disease may reduce the incidence of SLT-related complications. Though the Light study has shown that SLT has a good safety profile, other studies have shown a higher incidence of IOP spike, especially in eyes with heavily pigmented trabecular meshwork. Hence, be cautious when performing SLT on such patients. Corneal edema, peripheral anterior synechiae, and macular edema have also been reported. Does SLT improve the quality of life? In the Light study, there was no significant difference between the treatment arms when assessed with the EQ5D questionnaire. But this questionnaire has a low sensitivity for ophthalmology, especially for glaucoma, which is often asymptomatic. However, the laser first arm had better scores for the glaucoma symptom scale, which incorporates measures related to the side effects of glaucoma medications. What are the economic benefits of SLT as a first-line treatment? The laser-first approach resulted in overall cost savings of £451 per patient for the NHS, with a significant reduction in the cost of surgery and glaucoma medications. Initial SLT was more cost-effective than initial medical treatment over a 3-year period in the NHS setting. SLT has also been shown to be cost-effective in the Canadian healthcare system. However, the cost-effectiveness of SLT may differ in various reimbursement environments, and it may be particularly favorable in countries where branded rather than generic glaucoma eye drops are used. Besides considering the cost-effectiveness of SLT from the patient's perspective, another practical consideration is the cost-effectiveness of SLT for a glaucoma practice. So I recently set up my own clinic, which is a very exciting new venture for me, and I wanted to get an SLT machine. There are quite a few SLT machines to choose from, and it is much more cost-effective to have an SLT machine which also has the YEC function. Hence, your choice of SLT machine may also depend on how good the YEC function is. The laser machine I have in my clinic is the NIDEK YC 200S+, and I'm going to digress a little from SLT and share a bit about the YEC function of this machine. I really like performing YEC capsulotomy with this machine because it has a low plasma threshold, which means that the energy is delivered very precisely and I found that it was less likely to cause IOL pitting compared to some of the other YAG machines I have used. I've also liked that the aiming beam had 2 rather than 4 dots, which makes it easier to focus, and the aiming beam can also be rotated to avoid any cornea irregularities. Besides posterior capsulotomy, I've also used this machine to perform anterior capsulotomy for eyes with an anterior pupillary membrane. The YAG laser is precise, and it cleanly cleaves the membrane without causing any iritis, which could cause the membrane to recur. So when starting your own private practice, just as I've done, you might also want to consider investing in a laser machine which has multiple functions, such as an SLT machine, which also has a good YAG capability. In summary, SLT is an effective, safe, and cost-effective first-line treatment for newly diagnosed and treatment-naive POAG. And secondly, patient selection is important for the success of SLT. Thank you very much for your attention.